Hello, this is Anna Giulio from the American Lung Association. Thank you so much for joining today's webcast, leveraging the American Lung Association Hospital Community Benefit Toolkit to promote tobacco cessation across community providers, or community priorities, excuse me. We are going to start in a couple minutes. There are still a number of people joining, so please hang tight. Just a couple of quick things. If you've got any questions, please feel free to put them in the chat, and we'll be back with a couple more instructions very shortly and to start the webinar off very shortly. So be back in a minute. Okay, we're going to get started now. So thank you so much for joining today's webinar. We really appreciate you joining today, and I just want to take this opportunity to welcome you. Before we begin, I just want to remind everybody that at the bottom of your screen, there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection, including any programs or browser sessions running in the background that could cause issues. This webcast is being streamed through your computer, so for the best audio quality, please make sure your computer speakers or headsets are turned on and the volume is up so you can hear the presenters, and make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know via the Q&A box. That's one of those widgets at the bottom. The webcast is being recorded and will be available one day after this, so sometime tomorrow, and you can use the same link you used when you registered. And so we're going to begin the webcast now. If you've got any questions, either with technical issues or questions just about the presentation in general, please feel free to put them in the Q&A box. We're going to be answering them as we go and then as well at the end. So again, thank you so much for being here today. As I mentioned, my name is Anna Giulio. I'm the Manager of Lung Health Policy here at the National Office of the American Lung Association. And I'm really excited to present you this webinar today about our new toolkit around hospital community benefits in promoting tobacco cessation. And so I'm just going to start by giving a brief background on why we did this toolkit and why it's important. So not a surprise to anybody today, but tobacco use is a huge burden on society. It's the leading cause of preventable death and disease, and approximately 15% of the adults in the U.S. population smoke, according to the Surgeon General. And about 500,000 people are killed each year because of tobacco use. In addition to the huge loss of life, there's also a huge economic toll for tobacco use. Approximately $333 billion per year in both lost economic productivity and medical costs. The good news is we know people want to quit. According to a 2015 Morbidity and Mortality Weekly Report, almost 70% of smokers want to quit, and about half of smokers have tried to quit. About half of smokers receive advice from a provider to quit. However, only a third of smokers use evidence-based cessation treatment, and only 1 in 10 quit successfully. So to try to increase that reach and those number of people quitting, we are working with a different tool today, hospital community benefit requirements. And so this is part of what nonprofit hospitals have to do to continue to qualify as a nonprofit hospital. They've got to reach out and do activities to improve the community. And there's been some shifts because of the Affordable Care Act, and because of the assumed increased coverage in states that expanded Medicaid, and the idea that every state was going to. However, that didn't happen, so there's a little bit of a discrepancy there. But I want to turn it over to Claire Brockbank and Michelle Paterino to kind of go over both the toolkit and some of the requirements around the toolkit and community benefit. So with that, I'm going to turn it over to Michelle Paterino, and we will go from there. So Michelle?
Thank you, Anne. So my name is Michelle Paterino. I'm happy to be here today with my colleague Claire Brockbank, who owns Segway Consulting. Together we've done a lot of work in tobacco cessation. We've worked for state health departments in California, Colorado, Florida, Ohio, Utah, to name a few. But before we got involved in tobacco control, we each had a career in private health plans. We've worked with Medicaid, Medicaid managed care organizations. We've both worked with the Health Benefits Exchange in Colorado. We've worked with divisions of insurance and employer coalitions and other stakeholders in healthcare. So our breadth of experience and expertise has really enhanced our public health work, and I think it gives us a different perspective on what's possible and what success may look like related to tobacco control, because we certainly see it as a shared objective across public and private healthcare. So we've been really happy to be working for the last couple of years with the American Lung Association, with Anne, and with the CDC on topics related to tobacco cessation, health insurance, Medicaid, and systems change in general. So thank you for the opportunity. And this slide really is just to give you the illustration of where the toolkit that Anne mentioned lives on the American Lung Association website. So you can see it's under our initiatives, and then you can see there that there are several sort of chapters to this toolkit. So you can take the time and sort of click through it. There's more information here than we're going to go over in detail today. But if you have any questions on anything that's here, you can let Anne know about those questions, and we'll try and make sure that we get to the answers that you need to use this. This is the Segway Consulting website. Again, just wanted to make sure you know how to reach us. And if you want to see who is talking to you or what our experience is, you can find that here as well. So Claire and I really want to share what we've learned about community benefit and community health needs assessments, and why we think it's so important for state and local health departments to get involved in these assessments and these implementation plans. We really see an opportunity for you in state and local health departments, so we've laid out these objectives for today. We want to make sure that you all walk away and understand why community benefit, and particularly community health needs assessments, are important for you, be able to make the case for including tobacco cessation in a community health needs assessment plan, and gain some community support for some of the things that may already be your tobacco cessation goals. We want to make sure that you can determine exactly which hospitals have completed a CHNA, and if tobacco cessation was identified as an impact or prioritized in their implementation plans, and then identify resources for you to use if you start working with hospitals. Before we get started, though, we wanted to just sort of get a good view of who we're talking to. So we're going to ask you to let us know if you work for a hospital or hospital system, for a local health department, or for a state health department, and obviously other, because while those may be the audiences that the toolkit is really directed towards, we think that other folks who work in tobacco control will benefit as well. So we'll take a minute here and let you answer. Okay, so looks like we've got about 10% of you in hospitals, quarter of you with local health departments, a third with state, and a third with others. So this is a great representation. We appreciate you filling us in here. That'll help us as we move forward. All right, one more question for you then, especially since we have so many of you that work in hospitals and local and state health departments, and that is whether you have actually worked on a community health needs assessment. So So if you'll just give us a yes or no on that. Our goal is, if we have several folks here who have done this work, then we want to make sure we give you an opportunity to share your feedback, ask questions, make other points that we might have missed. All right, so that's great. About 20% of you have worked on a hospital CHNA, so we will look forward to you helping us to make this a richer topic and a richer session as we go. All right, so we are going to start with just sort of this view of health assessments and health improvement plans. This is probably obvious to most of you, but just to sort of lay the groundwork, we know that state health departments will do a state health assessment and a state health improvement plan that will cover your whole state. We know that local health departments will do a community health assessment or community health improvement plan. And just wanted to really illustrate that the hospital, a nonprofit hospital that's working on a CHNA, can do something at the local level, the state level, regional level. It just depends on how they define their community. So it may straddle both of these. All right, and again, the genesis for this, or the reason this came to be, comes from community benefit related to nonprofit hospitals. You're probably aware of this definition of community hospitals. Obviously, it's the initiatives and activities that are undertaken to improve the communities that they serve. A lot of us, I think, are familiar with the term charity care, and we know that hospitals provide care to people who can't afford to pay for their services. That's what we've heard about for a long time, that nonprofit hospitals, sort of hang their hat on how much charity care they provide. But this new requirement, or newer, on the Community Health Needs Assessment comes from the Affordable Care Act. So it stipulates that to be recognized as a 501c3 and maintain federal tax-exempt status, that hospitals are required to conduct a community health needs assessment and adopt a community health needs assessment implementation strategy every 3 years. The timing of this really coincides with the launch of the National Voluntary Public Health Department accreditation process, Public Health Accreditation Board, and so most of you probably know that completion of a community health assessment or community health implementation plan, a CHA or a CHIP, are prerequisites for local health department accreditation, and they must be completed to demonstrate fulfillment of the accreditation standards. So the CHNA requirement out of the Affordable Care Act and the CHA and CHIP requirement from public health accreditation are different requirements from different places, but they are going to look at similar types of data and hopefully drive similar opportunities. Now, I just want to take a minute and point out that while the CHNA requirements came from the Affordable Care Act, they are now part of the Internal Revenue Code. So when we hear about the repeal and replace, or what the future of the Affordable Care Act may be, we don't really have to worry about the CHNA piece of it now because it's part of this Internal Revenue Code. So you see the first 3 items there are really that charity care piece, and then the 4th item is the Community Health Needs Assessment and Implementation Strategy. So the regulations have been in place for 3 years now, and a CHNA really starts with a hospital defining the community they serve. So for the purposes of their CHNA, a hospital can define the community geographically. They can take into account a target population or specialized function like a hospital for women and children. But a community cannot be defined in a way that excludes medically underserved, low-income, or minority populations. And of course, identifying and prioritizing the significant health needs in a community, that has to go into each hospital's CHNA report. So they have to prioritize the significant health needs, give a description of the process and the criteria they used in identifying those needs, and how they determined that they were significant, and then they need to give a description of the resources that are potentially available to address the significant health needs identified. So obviously, your tobacco control programs can be part of that, description of resources to the extent that the hospital knows about them. And this is how the hospital knows about them, or how you make sure they become aware. The hospital must consider input from public health. So we know that doesn't necessarily mean you individually or your program, but presumably, most of you are from larger departments. You may have sister agencies, other local health departments, or if you're a state health department, a local health department, however that looks. So you may have to do some sleuthing to sort of figure out who has been involved and make sure that you're able to sort of join forces that way in terms of the other public health folks giving input. But if you have had frustrations with that, if you haven't been able to really figure out who's been the public health person involved, this is sort of another in for you. So you can submit comments, because hospitals must acknowledge written comments that they receive regarding their community health needs assessment and regarding their implementation strategy. So again, as we noted, it's two different sets of requirements, so two different sets of timing here, but there's certainly a bridge between hospitals and public health here. And while you'll need your own processes most likely, still there should be some collaboration, there should be an opportunity to build relationships, to do some education, leverage resources, and pool resources where you can. So the other piece of this is that the CHNA report has to be made widely available to the public on the hospital facilities website. And Claire's going to talk a little bit more about that, how you find it and how you use it in a minute. But just wrapping up this section of the webinar, the graphic here really is a reminder that there are lots of puzzle pieces, lots of players, including the folks at the hospital, state health, local health, but doing the figuring out who's involved, getting involved where you can, bringing the pieces together is really important, and we encourage you to take the time to do that. The bottom line is really that you may have similar goals, and we want to help you look at how to align those goals and get the biggest bang for your buck as you do this work. So Claire's going to talk next about more of the how-to related to community health needs assessment prioritization for tobacco cessation. But before we go there, does anyone have questions that we should stop and answer now? Okay, Claire, I think you can go ahead.
Just before Claire gets in, again, if you've got any questions, please feel free to keep them into the Q&A box, and we will answer them as they come up and at the end as well. So, but back to Claire and Michelle.
Hi, this is Claire Brockbank. Thank you so much. So what we're going to do, Michelle has now given you a good foundation of what the CHNA is and who it's supposed to include, et cetera. So now we're going to talk about specifically how does this apply to tobacco? How do you advocate to have tobacco cessation be one of those priorities that are, that are identified? And what's the first step to really getting started? What are some outcomes that you might find as you get into this work? And we'll quickly highlight some resources which are in the toolkit, but just to make sure that you're aware that they're there. So, but again, we had about 20% of you, I think, who'd worked on a CHNA. So question for those of you who have, was tobacco a component, a prioritized component, or in the implementation plan for the CHNAs that you were working on? And it looks like it's about 50-50, so that's not too surprising. It's good to know, and again, for those of you for whom it wasn't, we can, your insight as to why it wasn't will be helpful, as well as for those that did manage to have it be included. One other question, just to get a grounding as we go forward, many of you hadn't worked on a CHNA, but based on what Michelle laid out, do you see a potential opportunity to use these as a way of partnering with your local hospitals on public health issues? Great. Okay, so with that, let's move forward. What we're going to cover today, we talked about how it applies. So in looking at research that went through about 300 different CHNAs that have been done in the last few years, we had a ranking of what they most frequently prioritized, and tobacco came 7th. So that's not too bad, but clearly there's other issues that were prioritized more frequently, and you can see these on the list here. And they're not surprising for those of you who are in public health. These issues all have merit too. This graph, which it may be hard for you to see depending on whether you've maximized your slide or not, give you the top 12 or so that were prioritized, and again, across different regions of the country in different areas. All of these have some applicability to tobacco, with maybe the exception of obesity, which is the top ranked one, and maybe injury. And you could make a case, but it's not quite as direct as being able to explain how tobacco affects, let's say, cardiovascular disease or respiratory health. So this chart is in the toolkit, so you can take a look at it. And I don't know whether this tracks with those people who have been involved with the CHNA before, but it certainly tracks with the ones that we've seen and been involved in. So what we're going to do today, when you think about wanting to have tobacco included, so you want it to be one of these top priorities, your first goal is to get tobacco identified as a priority during the CHNA process, right? So to do that, during the process, you need to be able to articulate how tobacco may affect any of the conditions that the group is discussing. So how is it affecting cardiovascular disease? How does it affect diabetes? So that you can make a case that it's important. So the toolkit provides you talking points to articulate really specifically how does this affect each of those top conditions. How does use affect it? Because, again, remember in the beginning, you're identifying what are the drivers of poor health. So the talking points talk about how does using tobacco drive poor health in any one of these areas. Now, if tobacco isn't prioritized, so you come into the process where they've already come up with their priorities, or they're coming up with the implementation plan, or you're getting involved a little late, then your goal is to get tobacco incorporated at least as part of the action plan to address the priorities they have done. So again, you're not saying to the hospital, you picked the wrong things. You're not trying to convince them to change their priorities. The odds are that it was a difficult process. But what you do want to help them understand is that whichever of those 12 or 14 priorities that we showed on a previous slide they may have picked, that the odds are they can be more successful if they augment their interventions with tobacco cessation interventions. So again, the toolkit also provides talking points on how cessation helps impact those conditions. So we talk about use as driving the poor health and cessation as improving the conditions they have. In the toolkit, there are those double sets of talking points for all of those conditions that might have been prioritized. We're going to just do a few today as examples to give you a feel for how they work. So behavioral health, that was the very top, one of the top conditions. Obesity was the very first one, and obesity is a little more attenuated in terms of its impact to tobacco. So let's start with behavioral health. So if you were in the early process, you were doing a CHNA, and we're going to talk about some of the timing in a few minutes. Some of the talking points you could articulate if you're sitting around the table and everybody is talking about, and behavioral health seems to be surfacing. Some of those points that are important are that we know that 50% of people with mental illness and addiction smoke compared to, it's twice that of the general population. We know that even though they consume half of all the cigarettes, they're only half as likely as smokers to quit. So you have really exponential differences between them. So tobacco is clearly affecting behavioral health. Again, so that's making that argument that they really come together. We know that psychiatric disorders are more common among smokers. And again, the prevalence of depression is twice as high. And the critical thing here is among former and never smokers, so even former, because that's the segue into why it's so important to help people quit, because the quitting has some immediate ramifications for the prevalence of depression in the population that these hospitals may be looking at. So if we take the second part of that, where we said, how do you say not only is tobacco an important driver, but cessation is an important driver of improving anything you're doing with respect to behavioral health? We know from the research that smoking cessation, so actually getting to the quit point, is associated with reduced mental health conditions, better quality of life, compared to continuing to smoke. So again, this isn't just the issue of compared to people who've never smoked, it's those who used to smoke. And it's not just for people with severe psychiatric disorders. It really falls across the spectrum of mental health conditions, behavioral health conditions. The thing that we hear often surprise hospitals who distribute a lot of antidepressants. For many payers, that's one of their top pharmaceuticals, is that when you quit, the effect of quitting can be as positive to depression as actually antidepressant treatment, and most people would prefer to not be on medication. The other thing is that even helping people reduce their use of tobacco can reduce the dosage of antidepressants. So again, there's a real, very tangible value there for hospitals that are looking at their pharmaceutical spend. So, and in fact, one of the things that often doesn't happen is that NRT, is that as nicotine is reduced in the system, that antidepressant medications and other psychiatric medications are not reduced, and that can cause complications. So that's just an important message to provide anyway. So with that example, you see how to help explain, if your group is really honing in on behavioral health as a priority, how you get to couple it with tobacco, and if they're looking at behavioral health in the implementation plan, how you say tobacco is an important part of that. We're going to go through substance abuse a little faster. It's very similar. We know that smoking-related diseases, even with opioids and all of the other substance abuse deaths, that's kind of hard to say, that we see that smoking-related diseases are still the most common cause of death among individuals. We also have a common perception among both substance abuse treatment providers that tobacco dependence treatment is going to interfere with substance abuse, that you can't do it both at the same time. And we'll talk in the next slide about how that's not true. We also see some real links between people who crave, who abuse drugs also crave nicotine, that there's some very common neural pathways, if you will. So in some health plans and some workers' comp carriers, cigarette smoking is part of their predictive modeling as a risk factor for prescription opioid abuse. So again, opioids are certainly a hot topic legitimately right now, but the tobacco use, it's not a minor component of addressing opioid addiction. And in fact, we know that when you do address tobacco cessation, it's typically associated with about a 25% greater likelihood of abstinence from drugs and a more sustained recovery. So again, these are just examples of one of those top two conditions. We have a similar one for diabetes. I'm going to keep going so that we have plenty of time for questions rather than dwell on this one. It's in your slide deck, though. So now you have this concept of the CHNA. We know if we took the time to go through all of those conditions, we could make a pretty tangible tie-in to why tobacco is important. But what do you do to get started? Like, how do you find out who's doing a CHNA? What do you do? And our advice is to break it down into just a few very incremental steps. You want to know what hospitals in your area are required to do a CHNA and if they've done one. You want to download those CHNAs and their implementation plans, and you want to start tracking some key data points. And there are some shortcuts that we'll show you in terms of how to do that. But those three steps, finding out who has to do them, downloading them if they've done them, and tracking data is going to give you a great start on getting your arms around what kind of potential you have in your area. So the key data points And when we were doing this, we literally had a spreadsheet. It was not very sophisticated or glamorous. And we were tracking when was the CHNA, first of all, was the CHNA done? When was it done? Because remember, they have to do them every 3 years. Was an implementation plan posted? They don't always post an implementation plan. And Michelle talked about the ability to send a question in that they have to respond. That's a good question to ask. Like, was there an implementation plan that I missed? Could you send it to me? Could I find it? You want to look in those plans for what was prioritized. Those plans also have to indicate who was involved, which may help you find people in your agency that may have been involved or colleagues that you know with advocacy groups, et cetera, but people who may give you some entree to gaining a better understanding it. And the last thing is, if tobacco use was identified as a driver, does the prevalence in their report track with what you would have expected? As public health professionals, you probably have a pretty good idea of the tobacco use prevalence, even in your counties, and certainly in your states. And what we find is it's often, tobacco use is often very underreported, and in underreporting, it often doesn't get identified as a driver. And we're going to talk about some ways to find that out in just a minute. So some shortcuts, because that sounds like a lot to be trying to find out. So if you wanted to get started, it's pretty easy. It's remarkably easy to do literally a Google search for tax-exempt hospitals in Illinois, or all hospitals in Illinois and for-profit hospitals in Illinois. Often the Hospital Association will have those lists available. And so a little bit of Googling will help you find a list. You may find a couple lists and want to do a little cross-checking against it, but will help you find out who is it that has to do this. Then you want to do so now you know that St. Joseph's Hospital in Colorado needs to do it. Now you do a web search for their CHNA, because as we know, you have to post your CHNA on the website, as Michelle talked about. You want to save those CHNA plans. You just want to download them and their implementation strategies, because when you've got them saved, you literally are going to do a keyword search in those documents for tobacco and smoking. You don't have to read the whole document. Some of these are really long. And if you find, when you do that keyword search for tobacco or smoking, you don't find those, you can be pretty confident that it wasn't prioritized in their plan. And so you just mark that on your spreadsheet. That was a no, didn't identify it. You might find that it was identified in the plan, but not the implementation strategy. So again, we used a spreadsheet that literally had a column that said implementation plan and a column that said CHNA, and marked, whether it was a yes or a no, or yes, yes, or whatever. So those are some pretty simple ways to sort of figure out, if you will, how to find out what they've done. Okay? And I know that sounds like a lot of work, but we actually went through and did this kind of starting from scratch. We took 2 states, and we picked Oregon and Nevada. We wanted to literally time how long it would take us to get to that point of being able to say, I have found the hospital, I have downloaded their CHNA, their plans and their implementation plans, I have done a keyword search for tobacco or smoking, and I've figured out which ones have prioritized it, either in the plan and or their implementation plan. So Oregon had about 60 hospitals, and all but 2 of them had to conduct a CHNA, and that one took us about 5 hours. We did that first. Nevada, we were getting a little faster. There were only 40 hospitals, and only about half of them had to do it. It took us a little longer to figure that out because we had to do a little more cross-matching. But then to actually do the search on the CHNAs were much faster, and that took us about 2 hours. So my last piece of advice on this screen would be, don't let perfect be the enemy of good. You might miss a few hospitals in doing this, but unless you come up with zeros, the big goose egg, and you have nothing, the odds are you're going to have a pretty healthy batch of hospitals doing this, and that gives you a great starting point because you can't necessarily address all of these hospitals. Does that make sense? Okay. We have some questions going, but I'm going to go through this and then take a pause and take a look at the questions that you all have posted, so keep them coming. There are 3 possible outcomes when you do this. So on your spreadsheet, you're going to have 3 scenarios that you can kind of highlight in colors. The best case is that the hospital identified tobacco as a priority and it was included as a strategy in their implementation plan. So that's awesome. The worst case is you came up with nothing in either of them. And medium is it was identified as a driver, but it wasn't prioritized in the implementation plan. Whether you as a health department decide to focus on pursuing your best case hospitals to find out how they're actually proceeding with tobacco and trying to make sure they really do a good job, or whether you want to also focus on medium and worst cases, really depends on how many hospitals you're dealing with and what kind of bandwidth you have for follow-up, and just even the political orientation in your health department as to whether you focus on sort of making the best even better, so you have a case study maybe and a good example to say, look how effective this was, or not. So strategically, there's some thinking about which ones that you might want to do that are really going to be fairly specific to your own environment. If you find, in terms of proceeding in your best case one, what you want to do is then look at that plan. So now you do want to actually read the plan, and you want to say, well, what was it that they, what have they done? How could you contribute to that strategy? Michelle talked about this as an important mechanism for building bridges. So even just building a bridge with that hospital and meeting with some of those key players that were involved to make sure that if there are tools that you have in your local health department or your state health department that could expand what they're doing, it is a great way to start to build partnerships and resources. It doesn't mean that you should go in this thinking that the hospital is going to pay for a pet project of yours. That may come down the road, but first you want to be seen as a real viable partner. You want to make sure you find out when the CHNA was conducted, because if a new one is happening soon, Michelle talked about this being 3 years in, so some of the early hospitals are getting ready to embark on their second cycle. And so in some cases, you may want to just be making sure that in those best case hospitals that they maintain their momentum and you focus on their next cycle. In the medium case hospitals, this is where you can move the needle because they've seen tobacco as a driver, but they didn't carry it forward in their implementation plan. This is when those talking points for those 12 or 14 conditions we talked at the beginning become really important, because you can then apply those and say, well, you picked diabetes. Did you know that tobacco is a cause of diabetes? And did you know that, and you can start to work with them to say, how do we make your diabetes initiatives more successful by incorporating tobacco? So again, this is where you look at what actions they've prioritized for what conditions, and you use your public health perspective to know what you could do to be contributing to their efforts. You're not trying to get them to not prioritize diabetes. In the example I gave, you're trying to get them to realize tobacco is an important part of their work on diabetes. If the CHNA is going to be redone pretty soon, because you can tell from the dates, then you might want to contact the hospital to find out who's going to be leading the work, find out who was involved in the work, they have to post who they got input from and participated, to find a way for your agency to contribute. So in this situation where you have this medium case, it's likely that they'll be receptive to identifying ways to integrate tobacco control, especially if you're coming to them with existing programs that they may not necessarily have known about. So let's say you've got the worst case scenario. This one can be more challenging, but we talked a little bit earlier about looking to see what the prevalence of tobacco is. if they didn't identify tobacco as a driver, one of the things you can do as a public health agency, you can make a request for a data pull from their electronic health records. It is a legitimate HIPAA-exempt or HIPAA-protected request that you can make to say, in your electronic health records, and 96% of hospitals are using electronic health records that track tobacco use status, what was the tobacco prevalence that you found? And what guidance do you give from there? And that's probably worthy of a whole nother conversation, but there are very specific ways that you can frame a request to a hospital as a public health agency or as a hospital to frame a request to your own IT people that will let you extract that data in order to get a sense of where it fits relative to the priorities that they did pick. The odds are the hospitals actually don't know, haven't really thought about doing that. We see very few hospitals that have taken advantage of that ability in their EHR, so don't assume they know that. Don't assume that they figured out, just like most of us haven't tapped our full iPad, don't assume, or our iPhones, don't assume they have either. So one of the things that we think is really important, one of the reasons we think there's a lot of opportunity here is that even though we know that more than half of the hospitals in this country are required to do this. So that means since 2012, the regs were finalized a little later, but they've been doing these CHNAs. But the data suggests right now that the spending by tax-exempt hospitals on community benefits hasn't changed. And that hospitals, most of whom have only completed one CHNA cycle, are really struggling with how to have the most impact within the limits of their resources and expertise. So they're good at putting the plan together, but they are stuck. They're sort of struggling with how do I take my assessment and turn it into an implementation plan? And this is what you guys do best, right? So this is the place where you all can come into play in terms of saying, look, your plan was super good. How do we help you take that knowledge and turn it into something meaningful? So the next two slides are some resources. They're on the website. I'm not going to take too much time going through them, but the first set of documents from the Catholic Hospital Association really focuses on its resources to help hospitals do a CHNA. So they're having to figure this out also. So this really helps you understand their perspective and how you do a CHNA. The second set of slides is from the Oklahoma Hospital Association, and they're fantastic documents. They're really focused on the fact that many times hospitals, if they do identify tobacco, they start within their own walls, right? So they often say, we're going to address it in our immediate environment with our patients, our employees, our campus, et cetera. This is, again, a great place to ask about the electronic health record, to use it to say how many of your patients coming in are tobacco users, right? So that we can, because you can measure that. That's a great metric for measuring, so that if you put a program in place and you're really targeting your hospital, the inpatients, et cetera, you can track that. That electronic health record data is almost real time. So again, many hospitals aren't aware of that. So again, these are some quick resources. And again, focusing initially on working within the hospital. When you move beyond the hospital, which is really the goal, so if you start with hospital-centric activities and they get a little good with those, you help them with those, we anticipate what we're starting to see is they then look at more community-based hospitals. And again, we're not providing resources here because this is your domain. This is where it moves right into your sweet spot of what do you have in your community that they could help you with, they could help you promote, they could build bridges with, et cetera. So that's where we go from you've done all this advocating to now this is where you get to actually sort of be the star in terms of helping them understand your resources. So I'm going to pause for questions here, and we've got a few listed, and some of these may not all be for me, so I'm going to read them out loud, and then some of them, Michelle, may be appropriate for you. The first question asks, if they have to spend a certain amount on their implementation strategies identified through the assessment. No, they do not. So they have to do an implementation plan. There is nothing specific that says how much they have to spend. Some states do have those requirements. They have to report what they're spending on community benefit. So it is a publicly reported data, but there are no guidelines that say you have to spend X percent. And this is why helping them find ways to come up with benefits that get them good presence in the community, but that doesn't cost a lot, becomes super important. Oh, and again, thank you. One of our participants from Oxnard noted that implementation plans are required to be attached to the hospital's 990 report. So if you can't find an implementation plan online, we were able to find it in all cases but 3, I think, for Oregon, and those 3, they actually hadn't done their implementation plan yet. But it's possible that you can also go and look up the hospital's 990 report. So that's a great suggestion from Oxnard Health. Thank you. We got a question, do hospitals tend to hire firms to do these? Lauren, I actually don't know the answer to that. I think it varies tremendously. So I'm not sure I could make a blanket response to that. I
don't know if there's a blanket. I certainly know of some rural Colorado hospitals that have used one of my associates' consulting firms to do them. They've done a handful of them here, so it is something that there are firms who have some expertise there, but I don't know if that's the norm.
Yeah, there are definitely, we saw evidence in looking at some of the CHNAs that they sometimes hired people to help facilitate a process. So given that most hospitals should have at least one posted, you could probably take a look at the ones in your state and get a feel for what they've done. Then we have a question here about how or why cessation reduces depression. I think probably that would be best. We can send you some of the citation material, but the evidence in the literature again shows that cessation reduces your need for anti-depression medications. It may not get rid of them, but it will probably affect your dosage. And again, the citation, the pieces we had on our slide. Beyond that, if you have, oh good.
The citations are in the toolkit, Claire, too.
Yes, it is absolutely in the toolkit. All the citations are in the toolkit. So, and certainly we can provide further information if that's of interest.
This is Anne. We've got a question if the webinar is being recorded. It is being recorded. Additionally, the toolkit that Claire and Michelle referred to is on the Lung Association's website. That's lung.org/cessation-TA. And you can either click through it, and it's also available for download if you'd rather download it, or if you're a state public health department and want to pass it out to some of your colleagues at the local level. There's a bunch of different ways to do that. And then you can send questions to myself or Claire or Michelle, and we can happily answer them as well. And
we also have another. Go ahead.
Sorry. Nope.
We have a comment from Lehigh Valley Health, who has been involved in CHNAs, and they note that updated regulations require the hospital to report on the impact of the strategies listed in the implementation plans yearly on the 990s. So that's fantastic. So again, the 990s are a resource that we do not reference in the toolkit. So Anne, we may want to augment that with a note in the toolkit about using the 990s.
We can work on that.
Because that's a great resource.
Yeah. And we can pause for a minute to see if other people have additional questions. So we've got a new question about how do we get cessation resources in the community. So Claire, Michelle, do you want to take this, or I can take a crack at it?
How do we get the meaning?
How do we get cessation resources outside of the hospital setting, I think. So I can start, and then if you guys want, I can follow up on that. I think Some of this would be things like to offer cessation classes to help people quit outside the community, to work on implementation, to help. There are other settings to help people quit that aren't necessarily in the hospital setting, but can increase quit attempts. Cessation classes are the thing that I think of the first when I think of this, but I think there are many different strategies to use. And Claire, Michelle, I don't know if you guys have thought about this more.
Yeah, it really, like we're doing some work in Ohio. We're really helping some of the local health departments push cessation programs into the community, really look at disparate populations and where they might access their health care, look at social determinants of health and how people are accessing some of those resources and supports, like housing and some of those associated things. So there's a lot of strategies about really getting it outside of the hospital and outside of traditional healthcare providers. My background, my bias is to always start with the healthcare providers, and then to the extent you can, look to community-based organizations who have similar goals.
Any additional questions?
You also know that, of course, in terms of cessation resources outside of the hospital, there's also the what the health plans are doing. And some of the different medication programs, again, based on the work we're doing right now in Ohio, we've been happily surprised and impressed with how many of the county health departments have identified ways to access cessation medications to be able to provide to some of their target populations. A lot of the infant mortality programs involve a tobacco component as well. So again, those are all possible resources. I think the bigger issue is getting those community resources into the hospital's realm of awareness so that they know how to refer their patients once they leave the hospital, and they know what some of the resources are, particularly some of the ones that are targeted to populations, the LGBTQ population, the HIV population, et cetera, that typically need maybe more focused resources.
Great. And I will if people have questions, again, please feel free to continue typing them in. Just a couple of things to note, and in addition to having the toolkit online and available for download, there's a widget at the bottom of your screen that should say resources. One of those resources is the toolkit itself, so you can just download it straight from there. The other resource that's there, and we really hope you'll take advantage of this, is just a survey to kind of give us feedback and constructive criticism on how the webinar went. We always love to hear from everybody. It'll also be sent out tomorrow in your thank you email for attending the webinar. So, but if you've got more questions, we'd love to hear more questions and answer them.
I have a question actually to ask out to the participants on the phone, and that's just getting a sense of how many of you, and I guess we can't really get an answer to this, can we, are actually using some of those electronic health records as a resource to get a feel for what your health systems are identifying as top conditions in your community.
So if anybody has any experience with that, if you want to type in, that would be awesome in the Q&A chat box. Or if you want to email Claire, Michelle, or myself at the Cessation TA email address afterwards, that would be great information to know, and we'd really appreciate that. Okay, well, I think we're going to probably end a couple minutes early. So thank you, everybody, so much for attending. Thank you, Claire and Michelle, for presenting. Oh, there's one. Okay. So there was one more comment that was posted. So really looking forward to hearing from you guys. And so that last comment, just the idea that the regulations, the interim regulations were started in 2013, so hospitals may be in their second round of this. So thank you so much for joining us, and please feel free to reach out with any questions or feedback you may have. And we really appreciate you guys taking the post-webinar survey. And thank you again so much, and we will talk to you all soon. We're always available for questions or technical assistance or anything like that. So thank you so much for joining us, and thank you to Claire and Michelle, and have a great rest of your day. Bye.
Bye-bye. Thank you.